all the PSMA PET agents kind of being the same for the time being, can you talk about access and logistics moving forward? I imagine it's going to be a pretty dynamic year.
Yeah, sure. So for patients having a PYL or PSMA 11 scan, it doesn't change. The PSMA information will be there. The physician can take the decision. So for patient, it doesn't matter which tracer you get. What matters is to have the scan. So what differs between gallium-68, PSMA 11, and PYL is the production method, how you get there. Gallium-68 is obtained from a generator with the father element, which is germanium, and you wait that the father element decay little by little, and you can get a small amount of gallium-68 that you can use for making your tracer. The half-life is 1 hour, so you're limited in terms of capacity of production and the range of where you can ship it. The F-18, on the other hand, is produced in a cyclotron, so you have basically unlimited capacity of production and up to 4 to 5 hours of travel range to ship the dose. So you can basically, that's what happened with flucyclovine, and that's what will happen with PYL. You will have very wide availability of these tracers, such as FDG. You order it and you get it. Whereas gallium-68, PSMA 11, currently it's approved only at UCLA and UCSF. And so that's good for these patients, but not for the rest of the US. So I think what really matters is the availability of the tracer. One other parameter that will play a role will be the cost and the insurance. So there are multiple layers that will play a role for this. I don't know if that answered the question.
Great, thank you. Question? Oh, Carl.
For equivocal lesions, when you treat those patients with ADT, do you see a change in the lesion?
Well, if you see a change, it was a prostate cancer lesion. If you don't see a change, it was not.
So you do see a change like that?
Depending on the nature of the lesion. It's indeterminate, usually it's 50-50.
So Jeremy, there have not been any comparative trials, PYL versus the gallium scans, right? So there could be subtle differences.
There could be subtle differences. From my experience, I've read many scans with both tracers. The quality of PYL is slightly better for probably 2 reasons. The fact that it's F-18, the fact that the biology leads to even higher uptake. So the quality of image is slightly better with PYL. You see maybe a little bit more of tiny lesions, but on the report, it doesn't really change the staging of the patient. Gallium-68, PSMA 11 performs already very well, and the stage of the patient is not impacted. The clinical management will not be impacted whether you choose one or the other.
Concepcion, you have a question?
Yeah, very nice talk. So obviously the importance of this moving forward is the ability as we get to the next level, which is theranostics. So can you please comment, because it seems to me I recall an article that De Bono wrote regarding intracellular PSMA expression. And obviously, if we're looking at PSMA expression as a function of whether or not we're going to treat with theranostics, the ability to differentiate extracellular versus intracellular becomes a real issue.
So first of all, this would be a 2 hours presentation. I have many slides. I could talk a lot about that, but just on a Q&A like this, it's you need a bit more. I think most of the uptake is mediated via the extracellular expression. So PSMA is a transmembrane protein. 95% is expressed on the extracellular part. Then the ligands, they bind to it, and there is an enzymatic reaction. There is glutamate metabolism. It gets internalized into the cells after binding, and it stays there without any recirculation, and that's the main strength. You have a good, excellent retention time of the PSMA ligands after binding. So it stays there, you can make images with that, you can make treatments, and that's the main strength. Now, for the whole theranostics field and the PSMA-targeted radioligand therapies, of course, the imaging the question imaging is on the table, how we screen patients, how we select patients, how we can evaluate the response to therapy, how the PSMA expression is impacted by PSMA-targeted therapy itself. All these are questions. They're still open. I would love to do a talk about that. I have slides ready, but it's pretty difficult
tonight
to just
at 8
answer like
o'clock.
that. Yeah.
Yeah. All right. So yeah, I remember, prostate. One of the limitations of prostate was that it binded to the intracellular or the transmembrane, and that prevented the imaging of sort of active tumor. So good. So a question I have is biopsies. David, from your perspective, you get a report. If it's something that you can biopsy, I imagine you will want to biopsy because you want to do some testing. But if it's something you can't access, IR says, you know what, I can't get it. What do you do then? Do you believe what you see?
Well, obviously, if you can get tissue, it's important. But as we go forward, we have more experience with this and belief and trust, then maybe that's not necessary. And I've had, not with this agent, but with Oximum and other scans, that lesions, mesorectal and things like that, or in weird places, you probably could biopsy them. But then, the standard of truth here is that if you did something, did it go away? And that, if you spot radiation or something like that, you see it and it goes away, then they say, yeah, it was real. So, I trust a lot of them. But the other thing we're seeing is that we find other cancers like rectal cancers and bizarre ones in the mediastinum and around the prostate that aren't prostate cancers, and that's always an issue. Why it's always important to try to get tissue if you can.
Yeah, I agree. Jeremy, question for you: reimbursement. I think the worst thing we can have is all these great tools, patients being told that it's not covered. What's the experience been for you at UCLA now, having had PSMA 11 for half a year?
Yeah, so here you arrive at the limit kind of my expertise. It goes into very complex regulatory expert questions, all these layers of admin people. For long story short, it is not yet covered by Medicare. It is still in the process, such as implementing PSMA PET in the guidelines, which is in its NCCN guidelines, which is usually required by private insurance to cover it and consider to cover it. We applied, of course, for both labels, the primary staging and the recurrent setting. It was initiated only after we obtained the actual FDA approval, and then you have a lot of paperwork, so it just takes time. We have good hope that by maybe the end of the year or maybe 2022, in the worst case, it is done and it will be reimbursed. And I think they may be waiting to do it in parallel with PYL, I'm not sure, but I mean, dealing with Medicare is also another, it takes time.
What I've noticed with fluciclovine and some of the other drugs was there was that pass-through status for a little bit where you did get reimbursed for costs and whatnot. And then the question became, when that sort of ran out, what you did after that. But we're hopeful, and I think we need to engage a lot of the patient advocacy groups and the associations like LUGPA and the variety of medical societies to really advocate on behalf of this. Because from the nuclear medicine perspective, I think the government oftentimes looks at the radiopharmaceutical as a supply for us to do a test. But the truth is, it's a drug. And the requirements for FDA approval clearly show that it's a drug because they're requiring these phase 3 trials for approval. So I think that's something that needs to be corrected as well.
My experience has been, when it gets on, you can fly below the radar for a while. It gets on the radar screen, then you start seeing this happen. But and they try to fight back, but you have to fight back harder. Yeah. And if you do, and keep going to the next level with dealing with third-party payers, everybody's familiar with this, you frequently win. But then again, do we have time to do it? Let me ask you a question, Phil. We know that bone scans have sort of served us well, but we know that they do miss a lot of lesions, and we may be finding by doing scans like this or other things that come down the pike that a lot of these, in quotes, localized prostate cancers are in fact metastatic disease. Do you see the time when these sorts of scans replace technetium scans? And I know there was a shortage of technician for a while and some delays. So what do you see the future there?
I think it's inevitable because you have a tool that's better. And the only reason why people say no is because of the costs. Not the only reason, but one of the reasons is the cost. I think it's just a matter of how long before it becomes obsolete. I think the fact that so many of our clinical trials are based on bone scan and CTs is a strong reason why we need to continue using bone scans and CTs. But as more of the clinical trials start incorporating PSMA PET into the protocols, and we know more about the meaning and the fact that certain interventions lead to an improvement in outcomes, I think it's hard to justify doing both. So it's like at biochemical recurrence, if a patient comes in with a PSA of 0.5, I think it's a waste of money to get a bone scan and CT. If you're going to do anything, you should just go straight to the PSMA PET. At initial diagnosis...
But you know what happens? Because I had this happen in the clinic a few months ago, and it was a VA patient, and they said, well, we're not going to okay an oxygen scan until they have a negative bone scan and CT scan. And that's sort of reverse thinking.
Yeah.
needs to change.
That's the absurdity of the whole pre-auth and the insurance process, and I think it doesn't surprise me. We see that all the time, but I think as we get more comfortable with this and the payers start seeing this, I think they'll probably change. When we looked at sodium fluoride PET-CT, I remember the cost of a CT and a bone scan was pretty much equal to the cost of a sodium fluoride PET-CT.
Right.
So it was kind of silly, that we would do both. And I think we could look at the economics and I think create a pretty compelling case why maybe just the PSMA PET would be valid.